67-year-old man with a history of IV drug use presents to the ED complaining of high fevers, rigors, fatigue, dyspnea and a productive cough. And approximately 10 days prior, he had experienced symptoms suggestive of influenza. Despite an initial improvement, the condition worsened over the past 4 days, and his vital signs show a temperature of 39.5, heart rate of 115, a blood pressure of 95/65, and a respiratory rate of 24. And we're going to see the chest x-ray in just a bit. The question is asking what's the most probable pathogen responsible for the current condition, and it gives you a number of choices: Mycoplasma, Staphylococcus, Chlamydia, E. coli, and Klebsiella. So before we move on to the chest x-ray, let's go through the question itself. So there's a 67-year-old man with a history of IV drug use, so the demographics are going to be important in this one, I feel. Presents to the ED complaining of high fever, rigors, fatigue, dyspnea and a productive cough. And 10 days prior, he had symptoms suggestive of influenza. And despite the initial improvement, the condition worsened over the past 4 days. The vital signs show a temperature of 39.5, heart rate of 115, blood pressure of 95/65, and a respiratory rate of 24. Let's take a look at the chest x-ray now. So this is the chest x-ray that we see for this particular individual, which is a 67-year-old man with a history of IV drug use that's come to ED with high fever, rigors, fatigue and dyspnea and a productive cough. And approximately 10 days before, he had symptoms suggestive of flu. And despite the initial improvement, his symptoms worsened over the last 4 days, and his vital signs had a temperature of 39.5, heart rate of 115, blood pressure of 95 and a respiratory rate of 24. And we see the chest x-ray here, and this is very much what the UKMLA does. It won't state what the x-ray shows. It will allow you to interpret the x-ray, and obviously in the real exam itself, a computer generated test, it will allow you to magnify the actual image itself. So let's take a look at the chest x-ray. Have a think of what the answer could be. What does the chest x-ray show? What does the clinical vignette show? And then you'll be able to get the answer: A, B, C, D, or E. I'll give you another 10 seconds to take a think about this. Is it A, Mycoplasma pneumoniae? Is it B, Staphylococcus aureus? Is it C, Chlamydia pneumoniae? Is it D, E. coli? Or is it E, Klebsiella pneumoniae? So take a look at the chest x-ray. Have a think of why they've shown you the x-ray. Have a think of why they've told you the specific demographic of the patient. And have a think. I'm going to give you 5 more seconds. Right, we're going to go to the answer now. The correct answer is, as shown here, is Staphylococcus aureus. So who do we have? So how do we get to that answer now? We've got a 67-year-old man that's an IVDU, that's complaints of signs of infection symptoms, high fevers, rigors, fatigue, dyspnea, productive cough, and certainly previously he had symptoms of influenza, coryzal symptoms, but then he got better and then subsequently deteriorated after that. Certainly his temperature suggests he's got a fever, 39.5, anything over 38 degrees is a fever, heart rate of 115, and a blood pressure of 95/65, suggesting that maybe this is going into some sort of sepsis, including a respiratory rate of 24. The question is, what does the chest x-ray show? And then by knowing what the chest x-ray shows, you're able to then get the causative organism. Now, if you take a look at this chest x-ray, what you can actually see is the fact that, especially on the right lower lobe, there seems to be almost like a fluid level. Do you see that? And in a sort of almost globular shape. What that suggests to me is the fact that this is cavitatory lesions. This is cavitatory lesions, and you wouldn't be wrong in suggesting that maybe there is some sort of signs of pneumonia or pneumonia that could be the cause of some of the symptoms. And certainly there are shadowing on the right side, as well as the left mid zone as well, where it shows that there is certainly an amount of shadowing consistent with consolidation. But if you take a look at the right lower zone specifically, you will see an air fluid level. That suggests to me that there is cavitatory lesions. So the answer is going to be Staph aureus, because this, number one, It is a very well-known organism, which is takes a lot of responsibility for post-influenza bacterial pneumonia, which can cause a lot of severe infections, especially in immunocompromised patients, such as the ones that we see here in this particular individual, which is an IVDU. And if you have a post-influenza pneumonia, it can lead to a very rapidly progressive illness with a lot of significant manifestations to the chest x-ray, as we can see here. So what we see here is the fact that this patient has got cavitatory lesions of the chest radiograph, and in the context of immunocompromised with an IVDU, post-influenza pneumonia would suggest that this is most likely to be Staphylococcus aureus. Now, what about the rest of the available causative organisms? Well, A is Mycoplasma pneumoniae, and that's a very common cause of atypical pneumonia, but that normally affects younger individuals. And normally when people have Mycoplasma pneumonia, it's a lot milder than the severe symptoms that's normally described. And certainly Mycoplasma pneumonia very rarely leads to cavitatory lesions on chest x-ray, the ones that we see here today. Normally, patients with Mycoplasma pneumonia, they're almost called a walking pneumonia because they have a dry cough, they have a headache, but they don't have any severe symptoms, and certainly they won't be causing anywhere near the severity of symptoms as we see with this particular individual. Now, what about option number C, which is chlamydia pneumonia? Now, chlamydia pneumonia is another cause of this atypical pneumonia, but normally it comes on with gradual onset symptoms, which normally resembles a relatively mild respiratory tract infection rather than what we see here, which is acute and severe. And also, cavitations are extremely rare in the chlamydia pneumoniae. Now, what about E? Now, E. coli is normally associated with GI, gastrointestinal, and urinary tract infections, and pneumonia caused by E. coli is relatively uncommon, and normally occurs in the context of things like hospital-acquired pneumonia, especially in patients who have underlying illness, immunosuppression, or those who've had aspiration as well from the GI tract, or maybe post-intubation as well. Now, in this case, there's no clear link between this particular individual, the IVDU, and the post-influenza bacterial infection, and what we see here, which makes this a very unlikely agent. Now, what about E, Klebsiella? Now, Klebsiella obviously can affect patients who have got compromised immune systems, and often those with heavy alcohol use, and it can often present with what's been described as a bloody, thick, currant jelly sputum that's associated with destructive lung infection that can cause things like abscess. Now, even though it can cause cavitatory lesions, the preceding viral infection in this demographic makes Staphylococcus aureus much more likely as a causative pathogen due to the frequency it's found in post-influenza complications. So, as a summary, this is a tricky question. There are several pathogens that can cause severe respiratory infections here, but the combination, the key thing here to remember is that post-influenza-like symptoms, the severity and the acuity of the condition, including the cavitatory lesions of the chest X-ray, alongside the patient demographic as an IVDU, favors Staphylococcus aureus as the most probable causative organism in this particular scenario.